to my desktop. All right. So we're going to continue on with blood vessels, get into lymphatics, and then we have 2.5, technically 3 days for immunity, which is more than enough to get through immunity. So we're back on track. I'm not worried about us falling behind or anything like that. And then also, I don't know if I mentioned it last time, Madeline had brought to my attention on our schedule, March 4th is exam 2. It has a W next to it. It's supposed to be a Monday, not a Wednesday. March 4th is a Monday. Okay, so exam is March 4th, Monday. All right? Can't remember if we talked about that last time or not. Old man brain here. All right, so circle of Willis. What the circle of Willis allows is for in the brain to be a constant supply of blood. If there is a blockage, the blood could circle the other way. So how do we supply it? With 4 vessels. The 2 left and right internal carotids, the 2 left and right vertebral arteries, creating 4 vessels supplying it. The internal carotids, when they enter through foramen magnum, and they anastomose. That means they connect with another vessel. They connect with another artery. So that's the vertebral arteries. And we create that circle. That circle of Willis supplies the brain. There is the 2 anteriors and 2 posteriors of the cerebral, and then the 2 anterior posterior communicating. So why a circle? Like I said, if there's a block, we can continue to supply the brain. So that's what we're seeing here. There's our circle of Willis, right? As far as portal circulations, we talked about this. This is laying between 2 capillary beds. So between the intestines, there's our capillary bed. There's capillary invillus, that's in the intestines. And then the sinusoids in the liver. So how do they connect? We bring oxygenated blood through the SMA, the superior mesenteric artery, arterioles, capillaries. Okay, so we're in the fingers of the intestines. We absorb nutrition. Now this is deoxygenated but highly nutritious blood through superior mesenteric vein, intestinal vein, hepatic portal vein, and into the liver, sinusoids. Here's where we filter it. Then it continues on. Central vein, hepatic vein, inferior vena cava, heart, through the heart to lungs, out to lungs, back to the heart, into systemic. Fetal circulation. So when you talk about in the fetus, they don't need to really oxygenate the lungs because they are getting oxygen from the mother through the umbilical cord. The lungs are not being exposed to air yet, so we kind of bypass them. There is some blood going there because they need nutrition to grow and develop, but it's not tons of blood like once we're born. So the first bypass we see is ductus arteriosus. This is when it's open. This is in the fetus. And it's connecting pulmonary artery and aorta, so the 2 great vessels coming off the heart. When they take their first breath and we see the shift in the lungs and they inflate, we create a low pressure versus high pressure in the pulmonary artery and the aorta. And the ductus arteriosus starts to collapse in on itself and becomes ligamentum arteriosum. It fuses, it closes. Takes a little bit after birth. It's not an immediate. Foramen ovalis is between the 2 atria, left and right atria, creating once again a bypass. When they take first breath, because of that shift in pressure in the lungs, an immediate shift in pressure between left and right atria, the fossa ovalis flaps closed. So it's kind of like 2 flaps like this, and when they take that first breath, it sticks to itself, and it should fuse. It doesn't always fuse. Sometimes people, when they're sick, stuff like that, we can hear that murmur between the atria. And once at a blue moon, they have to go in and surgically close it. But for the most part, everyone first breath, it kind of closes up and closes up pretty quickly. They can give it a bit of time to close if it doesn't want to close immediately. Once it closes, it becomes fossa ovalis. So in the adult, fossa ovalis. So when you guys were looking at the heart models, it's that little divot between the 2 atria. All right, fetal circulation. So we have some unique things going on here. Umbilical artery. Arteries go away from the heart. This is carrying deoxygenated blood to the placenta. The umbilical vein brings oxygenated blood back to the fetus. So remember, veins return, arteries away. So there's 2 umbilical arteries, 1 umbilical vein. Remember, blood between the mother and the fetus does not mix. You have placenta and you have uterine lining. They're kind of invaginated in themselves like this, but they're not mixing. If it mixes, that's catastrophic. Okay, so it does not mix, but the fetal hemoglobin, which is alpha gamma hemoglobin, and ours is alpha beta as adults, the want for oxygen is so much higher. The affinity for oxygen is so much higher. The binding capacity of fetal hemoglobin is so much stronger that as the blood passes close in the mother's blood supply and the uterine lining, close to that of the fetal hemoglobin, the oxygen will leach out and pass on to the fetus's hemoglobin. Okay? So anytime we create deficits in the mother's oxygen supply, we create deficits in the fetus's oxygen supply. That's why like smoking is a big no-no for the mother. Smoking creates carbon monoxide. Carbon monoxide irreversibly binds hemoglobin. There's not as much carrying capacity in there. The mother is not carrying enough oxygen. It causes slower fetal development, amongst other issues, right? Blood pressure. So we talked about this diastolic. When we say diastolic, systolic like this, remember we're talking about like ventricular. We're talking about rest versus pumping. So systolic is our top number, diastolic is our lower number. So blood pressure is created when we eject blood out into the aorta. And we create through the entire system this increased pressure. That pressure pushes in all ways, including on all the walls of the arteries, so the arteries expand and then contract. And that's what we're going to be measuring to reach or to measure blood pressure. We're measuring that pressure expansion and then how much is the lowest amount of pressure to push through an occlusion. Okay, so we look at it in millimeters of mercury. So remember your units. And I know here it says normal is 120 over 80. It's a range. Not everyone's 120 over 80, okay? There is a high and a low normal range for each. So what's going to affect blood pressure? How much the heart is pumping out, the rate the heart is pumping at, the volume of blood coming out. That's all cardiac output, stroke volume times heart rate. That's blood volume, cardiac output. Chemoreceptors, baroreceptors, we're going to talk about these in peripheral resistance as well. So you can measure blood pressure in several places, okay? The most common is brachial artery. So what we do is we apply a cuff. We take the cuff up to 200. So this is the technique I was taught. When you do that, you occlude the artery. Blood cannot pass. So the artery is completely compressed. As you start to release it ever so slightly, blood can rush through and creates the first sound of cough. That is the first sound you hear. That is your systolic. As we expand, or release the pressure in the cuff, eventually the sound disappears. When the sound disappears, that is your diastolic. That's the second sound of cough. Okay? You'll see with patients something called like white coat syndrome. White coat syndrome is patients develop high blood pressure when they are going to see like the physician. It's a fear. And so sometimes we need to take blood pressure over extended periods of time, or sometimes we have the patient, get a machine, take it at home in the comfort of their home and see if that affects it. But yeah, you can see people jump up substantial amounts from white coat syndrome. Or they'll do stuff like drink coffee before getting their blood pressure measured, okay? So stimulants, it's going to increase blood pressure because it's going to increase heart rate. It's going to increase vasoconstriction. Blood pressure is going to go up, okay? Pulse pressure. So pulses how many times the heart is beating, its heart rate. Every time we push out into the aorta, we push out into all the vessels expand, that's pulse. Okay? That's what we're feeling, that bound and recoil, bound and recoil. Pulse pressure is systolic pressure minus diastolic pressure. So the higher the systolic pressure with a low diastolic pressure, the higher the pulse pressure. That means there's an excessive amount of force constantly pushing on the vessels. That's not good. Okay, so that's why, systolic, you want it to be lower. Diastolic, you don't want it to climb too high. Also, because then we're not getting a resting pressure. Even though the number may be tighter, the resting pressure is still very high. You do have to have a certain amount of pressure, which is mean arterial pressure, and we'll talk about that, to perfuse the tissue. If that pressure isn't there, we're not pushing out into the tissue. We're not providing nourishment to the tissue. As far as taking pulse, really anywhere you can get to an artery and you can feel it. Bigger arteries are used for like when patients have low volume, stuff like that, or say someone has an amputation, right? You need to be able to read it in different areas. So mean arterial pressure, that is an average blood pressure. So it's interesting because how we calculate it, you take diastolic plus pulse pressure divided by 3. We should end up with a number that's close to diastolic pressure. So really this is representing the average pressure inside the arteries that is perfusing the tissue. If MAP drops too low, you don't perfuse important tissue like the brain. You get into trouble. So sometimes, when you have like a patient with a hemorrhagic stroke, well, we don't want blood pressure too much because they're going to keep on hemorrhaging. Well, at the same time, if it's too low, we're not going to perfuse the tissue and cause the same damage. So it's this balance. This is where, you're using vasopressors to increase pressure or vasodilators to decrease pressure. We're controlling heart rate. It becomes a balance. And that's why it's really important with these meds that we're dosing them correctly and we're administering them at appropriate times. You want a pharmacist to lose their mind, miss giving one of these meds. You skip it, we get into problems. Now pressure can go high, they can hemorrhage. Pressure can go, if we're giving vasopressor, pressure goes too low, hypovolemic shock and damage. Not enough pressure to perfuse the tissue. Destruction, permanent destruction potentially. So it's very important to dose these meds appropriately and administer them in a timely manner. So on the exam, I'll give you guys a calculator. Don't worry about that. But you do need to know how to calculate these. So they give us an example here. Blood pressure is 120/80. Pulse pressure, we take systolic minus diastolic. There's our pulse pressure. We then take diastolic plus 40 divided by 3. 3 is a constant for us in this equation. And we end up with 93, close to diastolic. You start getting this number too high, you risk hemorrhage. Okay? So diastolic, when you look at high blood pressure, diastolic creeping over 89, they are hypertensive. Systolic can go up to like 139. They may have changed the guidelines a little bit, but last I remember, 139. That's a big margin versus diastolic can go up 10 points and we're in trouble. Systolic could go up 20 points before we're in trouble. Okay. So that resting pressure, mean arterial pressure, that's important to keep low. So affecting blood pressure, talked about these. So cardiac output, the more we put out, the more blood is in the system, the higher the pressure. So if we increase heart rate, more cardiac output, more blood pressure. We increase stroke volume, more cardiac output, more blood pressure. We increase general volume. I put more into your blood vessels, like I give you saline solution, more cardiac output, more blood pressure. So blood volume, that's what we're saying. More in there, more blood pressure. So when you have a well-hydrated patient, they should have more appropriate blood pressure. What will happen to their heart rate? As you give someone fluids, what should happen to their heart rate? Blood pressure is going to go up. What should happen to heart rate? You administer fluids to someone. They well hydrate themselves. Their blood pressure goes up. What should happen to their heart rate? Come on. Take a guess. If we increase, what's going to happen to blood pressure overall? If heart rate stays up and I'm giving them fluid to increase their blood pressure and both go up, what's going to happen to blood pressure? Wakey, wakey. Are they going to maintain blood pressure? Is blood pressure going to increase? Or is blood pressure going to decrease? If you put fluid into someone, their blood pressure will increase. If their heart rate increases, cardiac output increases, blood pressure is going to increase. When you give fluids to someone, you're giving more blood volume. Blood pressure will increase. As they reach normal blood pressure level, heart rate will begin to decrease. You're going to decrease cardiac output because you have the blood pressure that you need. This is where the baroreceptors come into play. They are seeing there is enough pressure in the system that we can decrease cardiac output. So there's this inverse relationship that if someone loses blood pressure, heart rate starts going up to maintain blood pressure. It's going to increase cardiac output. We're going to increase heart rate to increase cardiac output. If your blood pressure increases, heart rate should decrease. Inverse relationship. So baroreceptors, carotid sinus, aortic arch, they are measuring pressure in these vessels. If pressure increases, the heart rate slows. Chemoceptors, your book says CO2 and pH. Ignore the O2. O2 has nothing to do with this equation. Okay, I don't know why it's in here. O2 is irrelevant. CO2 and hydrogen ion. Really, hydrogen ion. Your book says CO2. Fine, we'll go with that. As your body undergoes cellular respiration, as metabolic activity increases in your cells, you burn through ATP. So what do? You make more ATP. Well, byproduct of this is CO2 and hydrogen ion. Hydrogen ion means tissue is under stress, tissue is working, which means we need to circulate blood. This will increase heart rate. This will dilate vessels so we can get blood through there. Okay, the muscle is working. We need to supply it with oxygen. They say low O2 levels in here, but it's not low O2 levels, okay? The amount your oxygen in reality drops on your hemoglobin is virtually nothing, okay? Oxygen saturation levels dropping, it's virtually nothing. So really, the big factor here is CO2 and hydrogen ion, and really hydrogen ion because it freely flows through the blood-brain barrier, stuff like that, very easily, okay? So baroreceptors, pressure receptors in here. As pressure increases, it slows the heart. So this is one of those, old techniques, carotid massage. Carotid massage is patient comes in with elevated heart rate, does not want to calm down. We can apply pressure to the carotid sinuses here and eventually, by increasing that pressure, stimulate the baroreceptors and decrease heart rate. Patients can pass out, so it's not like something that's willy-nilly done. You shouldn't just, I feel my heart rate's fast, I'm just going to do this. You're going to do that, okay? Don't give yourself a carotid massage. So baroreceptors, same thing. If there's decreased pressure, they'll stimulate the increase in heart rate, vasoconstriction to bring blood pressure up, and stimulate those baroreceptors and reach homeostasis. The body is all about keeping homeostasis. So increasing blood pressure, hormones increase blood pressure, epinephrine increases heart rate. So there's increased cardiac output. Constriction of arteries and veins. Well, that's increasing preload because we're turning more, and we're increasing blood pressure because we're containing the compartment. So all of that is going to increase blood pressure. Volume of blood. The more water you drink, The more volume, the more blood pressure, slower the heart rate. If you're ever dehydrated, you'll notice you may feel flutters, you may feel, heart rate's pounding away. It can be a sign that you're dehydrated. If you increase the amount of salt in your diet, that's more osmotic pressure. That is more solute in there holding on to water. More water, more blood pressure. And then peripheral resistance. As there is more vessels or there are more cells, there is resistance, there is push, there is more blood pressure. So peripheral resistance really has to do with arterial diameter. And all you guys really need to take away from here is if you decrease the diameter by half, you take an artery and you decrease it by half, or an arterial, you increase the resistance 16 times over. If you dilate it by half, you decrease the resistance by 16 times. Blood viscosity, this is that polycythemia, harder to flow. More pressure, more resistance, more the heart has to work. And blood vessel length. As our mass increases, there are more vessels, there's more blood, there's more for the heart to push against. The pump has to work harder. The muscle starts to get thicker. The amount in the ventricles is less. So what do we do to maintain blood pressure? We start to speed the heart up. Now the heart is working harder and harder and harder. And eventually it's going to get overworked. Eventually there's going to be a clog in the coronary arteries and heart attack. So treating high blood pressure, there's lots of ways. Either you decrease the amount of volume of blood, you slow the heart down, or you dilate the vessels. It's kind of one of the root 3 ways to solve it. So beta blockers, they slow the heart. Calcium channel blockers, they dilate a blood vessel, so that's your decrease in peripheral resistance. They also slow the heart. What else? Diuretics, this is your removing blood volume. So Lasix, hydrochlorothiazide, the water pill. Okay, so many ways to reduce it. There's tons of diuretics out there. Lisinopril, which actually reduces aldosterone production that we'll talk about. So less sodium in the bloodstream. Because there's less sodium, there is less water held on, less volume. It's not technically a diuretic. And then peripheral resistance, vasodilators, so calcium channel blockers. And then even you look at like nitroglycerin, technically falls in that category. Sildenafil, which is Viagra, can be used, but that's more for pulmonary hypertension. Nutrient exchange in the capillaries. All right, these pressures. So I'm going to switch to the camera. And we're just going to use the board for a minute. Let me get one of my markers. These markers are pretty crummy. All right. Vessel, cell, red blood cell, interstitium or interstitial fluid space, interstitial tissue. Your book wants to teach you the very basics here, or this class, we teach you kind of the very basics, but if you understand the general concept, your life becomes a lot easier. So in my Path Phys class, we teach all of these, and it just kind of clicks for them at that point. So I've been teaching it for like my AMP2 students, and I think they have a better understanding of the topic when we do this. Hydrostatic pressure, so let's do this. Is push of water. Okay? Osmotic oncotic is pull of solute. So your book refers to it as osmotic pressure. When I was in school many moons ago, it was oncotic pressure. Depending on the book you look at, oncotic pressure really refers to albumin, protein. Protein is the biggest solute in our bloodstream that we really talk about in cells themselves. But your book likes to go with osmotic and saying the other solute floating in there, and they really like to target sodium chloride, salt. Okay, they all play a role, but in reality, albumin is the biggest role. Okay, they act the same, osmotic, oncotic pressure, one and the same. Okay, there is solute in all of this. There is fluid in all of this. So when you look at this and your heart beats, there is a pressure that is pushed through here. That is hydrostatic pressure. It is pressure of fluid. Hydro, water. Static because it's intermittent. It actually fluctuates with every heartbeat. That pressure pushes in all directions. What we're concerned about is this one. Hydrostatic pressure pushing into the vessel, or into the interstitium. This is blood vessel hydrostatic pressure. Osmotic or oncotic pressure is the pull into here due to this solute right here. It's pulling it back. So if I say this hydrostatic pressure is 10 millimeters of mercury, and this osmotic pull back in is 3 millimeters of mercury, that means 10 minus 3 is 7. 7 millimeters of mercury pushing into the interstitium here. There's extra fluid in here. What we'll see is this is where lymphatics come into play. Lymphatics are blind-ended drains that'll take that fluid and drain it out. So the kicker here is every single compartment has these two forces. Inside the cell, intracellular, osmotic pressure pulling into it. There's solute in here that's going to pull in. It has water inside of it, so it has intracellular hydrostatic pressure. This is technically extracellular fluid, so extracellular hydrostatic pushing out, extracellular osmotic pulling in. Interstitial fluid has hydrostatic pressure pushing this way, osmotic pressure pulling that way. Interstitial tissue has the same two forces as well, interstitial hydrostatic, interstitial osmotic. The reason I teach this is what happens when you inject into someone a hyperosmolaric fluid, meaning our bloodstream is usually 0.9, it's like more like 0.8% NaCl. And you put into that patient a hyperosmotic solution, or they drink salt water, for example. Well, you drink salt water, and let's say that's 20% sodium. We have a problem. Now in my bloodstream, I have lots of solute. The osmotic pressure increases. So what I see is water follows solute. Water will drain from here, water will drain from here, water will drain from here. And then your kidneys are going to go, there's too much salt in your body, we don't need it, and pee it out, and water will follow it out. So when someone's stuck out at sea, that's what happens. That's why drinking salt water like super dehydrates them way quicker than not drinking water. Okay? Let's say like not erasing nicely at all. The eraser's done. Let's say someone does something silly and they drink pure water. That's a problem. This is a hypotonic solution they've consumed. Or say you put a IV solution into someone and you don't match their sodium level and you give them no sodium in there, this is a problem. Water rushes into here, water rushes into here, water rushes into here. What happens to the cells when water rushes in like that? You put an animal cell in a hypotonic solution. What happens to the cell? It bursts, explodes, lyses. Okay? That is a big old problem. Specifically, there's your oxygen carrying capacity. That could be gone. And then we rush into here, we rush into here. This is edema when it's in here. In the brain, if that's a neuron, they demyelinate and the patient dies. Okay? So these pressures will shift compartment to compartment. In this class, they're keeping it simple. They're going to just say hydrostatic pressure from the blood vessel pushing out, and then osmotic pressure, solute pulling water back into the blood vessel. You will have to calculate this, and you have to tell me where the pressure is going. Don't just tell me 7. 7 where? 7 into the blood vessel? 7 out of the blood vessel? You have to tell me. Okay? I can't assume that you did the math right and you understood that it's 7 out. You have to say 7 millimeters of mercury out of the blood vessel or into the interstitium. Okay? Then we'll switch back. So hydrostatic pressure is pushing out. Ignore this arteriovenular end. That is so confusing for no reason. Just ignore it. It is hydrostatic pressure and that's it. Don't try and split it and calculate it. Don't worry about that. Osmotic pressure is the pull in. And really the biggest factor, like I said, was albumin. Your book likes to say sodium and all of that. Yes, it plays a role, but it's not the big role. Albumin really is. And that's why it's truly an oncotic pressure, which references protein. So here, for example, they have 30 millimeters of mercury pushing out, 22 millimeters of mercury pulling in. The answer here should be 8 millimeters of mercury of fluid pushing out of the blood vessel or into the interstitium. Don't worry about that, okay? So here, they're getting confusing. We won't do this to you. We're just going to give you hydrostatic and osmotic and have you calculate it, okay? So here in this sense, there is 30 millimeters of mercury pushing out. There's 22 pulling in. Net filtration out, 8 millimeters of mercury. This would be a completely different problem. We would say this patient has 15 millimeters of mercury pushing out and 22 millimeters of mercury pulling in. So 7 millimeters of mercury are moving into the vessel. Treat them like two different problems. Don't try and stack it together, okay? So the bulk is typically out because we have to provide nutrition to the tissue. The problem is there's excess fluid out here. If we do not pull that fluid back in, that 8 millimeters of mercury, we're going to have edema. So how do we drain it? The lymphatics. The lymphatics are going to remove that interstitial fluid. They're going to drain it. If the lymphatics are dysfunctional, they're clogged, or they're compressed, that's lymphedema. It is this edema because the lymphatics are not draining it. So lymph vessels They're just pressure valves. They're very similar to veins. Simple squamous. They can allow some protein into them. They can allow cells to move into them like white blood cells. They're sampling the environment because they're more superficial. So like when we get like debris in there, bacteria, stuff like that, they can alert the immune system. And then they have valves throughout them. They work by muscle milking, just like veins, and they drain that excess tissue. So they're going to drain it and go through the subclavian and then drop it into bloodstream. So like I said, blind-ended, they're like sewers, right? You have like a sewer that ends at your street and then it drains back to the main sewer place, whatever you want to go with. They have valves in them, simple squamous, and muscle milking. So edema. Why does edema happen? There's so many reasons. But if we keep it basic, we have to create high pressure out that's exceeding what can be drained. We have to obstruct the drain, or we weaken this system here, the osmotic pressure. If we do any of that, more will flow out, or we open the doorways more. Between your cells are your blood vessel cells. They're not solid. There are gaps in there. So there's little gaps like that that allow for fluid to pass. Well, if you open those gaps wide open, things readily pass. Okay? So increasing venous pressure. If you're not draining the veins, pressure will increase. What part of the heart is failing for you not to drain the veins of the body? What part of your heart is failing for you not to drain the venous system of the body? The systemic system, the right. Right ventricle fails, you back up into right atrium, you back into SVC, IVC, fluid in the body. There's your systemic edema. If the left side fails, the left side of the heart fails, left ventricle fails, right atria backs up, pulmonary edema. It's the same concept. Low osmotic pressure. Who makes albumin? What disease state is going to have low osmotic pressure due to loss of albumin? We talked about this at some point. Liver failure. The liver produces albumin. So in cirrhosis, they're not producing albumin. Big old beer belly. It's fluid. It's an edema. It's peritonitis potentially. Okay, the peritoneum is filled with fluid. It's inflammation. Okay, the infection, they can have what's called spontaneous peritonitis. The bacteria migrate from the gut into there, and they get infections. Blockage of lymphatic vessels. If you took micro, that's the filariasis organisms. Wucheria bancrofti. Okay, and the cool name, guys. Or we see it, if you watch like My 600-Pound Life, because of the excessive fat, they're crushing the lymphatics and it's blocked. Or if you've ever seen a woman and she's wearing like a compression sleeve, the reason is she's had what's called a radical mastectomy. They've removed the breast tissue and they've removed the axilla lymph nodes. Because they've done that, it can't drain. So what they're creating is, by putting the pressure on here, they're compressing this, they're increasing interstitial hydrostatic pressure and pushing the fluid back into here. They're basically fighting this force so that it'll drain back into the veins and out. And then lastly, increased capillary permeability. This is your hypovolemic shock state. It creates hypovolemic shock, I should say. This is what's happening is the vessels are opening way up and now fluid is just flooding out into the interstitium. Blood pressure tanks, heart rate skyrockets. They are in trouble. Right? So commonly we say with bacterial infections, but that's not 100% true because it's actually your white blood cells that are causing this. They are releasing histamine and heparin like wildfire. So you see this in anaphylaxis. You see this in like ABO mistype, if someone the wrong blood type can cause this. DIC, disseminated intravascular coagulation. They coagulate, they use all their platelets, and they start bleeding into the interstitium. Ebola, amniotic fluid getting into the mother, any of those situations can trigger it. And then toxic shock syndrome, where like a woman wears a tampon for too long, and the bacteria in there, they release lipid A, LPS if you took micro, and then the white blood cells react, releasing tons of histamine, heparin. Blood pressure tanks. So here they're showing, that would be like the woman that had the radical mastectomy probably. See how one arm is swollen, one isn't? This is angioedema. This is congestive heart failure. And then we can even see it like in hernia situations. There's, I forget the proper name for it, but that's actually fluid-filled scrotum. If you hold like a light up to it, you can see clear through it. Essentially, the light will shine right through. It's full of fluid. Shock. AMP2 doesn't shock people, okay? All shock is the system is not adequately providing nutrition to the tissue. There's not enough pressure for a myriad of reasons. For some reason, either the heart isn't pumping fast enough, it can't pump fast enough, or we're losing blood pressure for some reason. How you get there? So many different reasons. Okay? End result, we're not making ATP, we're not undergoing cellular respiration, tissue is dying potentially. There is that risk. So, cardiogenic, heart stops. That's it. No cardiac output, no stroke volume, no heart rate, no pumping, no oxygenation. So they give it not heart attack, cardiac arrest, okay, and electrocutions because it can stop the heart. That's pretty much it. Anaphylaxis, this is where there is a grand release of heparin and histamine, and vessels open like crazy, blood pressure tanks, heart rate skyrockets, we're in trouble. Neurogenic, this is extreme vasodilation. When there's brain damage, extreme vasodilation, blood pressure tanks. Heart rate skyrockets, we're in trouble. Obstructive, so we'll see this with typically pulmonary embolisms, the saddle embolism specifically. A grand old deep vein thrombosis climbs up through the inferior vena cava, gets into the right atrium, goes out right ventricle, and then saddles on the arteries where they split into the lungs and just occludes it. These are incredibly dangerous. Most people don't survive these. Okay, that's really where you talk about that. Septic, so this was like the toxic shock syndrome, and really any bacterial infection potentially could trigger this. White blood cells respond, they release tons of histamine, heparin, and we go into septic shock. And then hypovolemic, this is sudden loss or severe loss of fluid volume. So extreme dehydration, not like, oh, I'm thirsty. No. Like this is marooned on an island dehydration. Extreme diarrhea and vomiting. That being said, when I say extreme, I'm talking about like average adult. You look at children and elderly, it doesn't take that much for them to get into a potential state like this. Okay? Burns. They just lose fluid. Your skin helps keep fluid in you. So once you have a certain amount of burns, they lose fluid like wildfire. So burns are extremely dangerous. It doesn't take much to end up with some bad burns. I know a guy, he owns a nitrous outlet, one of the biggest like nitrous companies for like cars and stuff. And like a dummy, he'll say he's a dummy for doing it. He went to burn a bunch of like leaves and whatnot and threw gas all over it and lit it. And it basically blew up, caught him on fire. And I think he had like 60 something percent of his body burnt. ICU, long recovery. He's fine now, but it's rough. Okay. And you'll see people get into accidents like that around fall time. They decide to burn stuff instead of putting it in bags and trying to dispose of it or composting it, and you'll see cases like that. All right. So when we go through the different levels of shock, you look at how the body is responding. So it's funny, my wife and I were having this conversation in the car last night. We're driving back from the airport. This is the conversation we're having. Shock. All right. The body is not a on-off switch. It's always responding in some way or another. The systems are all always kind of working. It's just how active are they or not. So compensated shock is the patient is sitting in bed and they start huffing and puffing. Their heart rate starts to climb. Okay? Blood pressure maybe not really climbing. It's kind of confusing in the notes here because it says low pulse, low breathing, low blood pressure. No. They are compensating. They are responding to these situations and trying to bring the system back to normalcy. So you see sympathetic kicks in. We kick up heart rate. We open up the airways. We tighten down the vessels. We are compensating. So this is, you're looking at the patient, you're like, oh, you don't look so good. We probably need to do something about this. Okay? This doesn't look good. They're compensating. So heart rate coming up, blood pressure trying to come up, maybe it's in the norm, and then they're breathing pretty rapidly. They're trying to make up for the deficits. Decompensated. This is you are pushing the code button. You're calling everyone. They are starting to tank. They cannot keep up with the demand. Heart rate is through the roof. Blood pressure is tanking. They may be hyperventilating. They are trying to breathe. They are trying to oxygenate. It's not really happening. This, if not recovered quickly, there's going to be organ damage. This, we need to get them under norm. So this is where we're giving them vasopressors. We're dumping fluid into them. We are trying to get them back to normal before we're in big, big trouble. This is an emergency situation. Irreversible. This is you are coding the patient. This is we are doing compressions. We are pumping vasopressors into them. We're calling the priest kind of thing, okay? This is your code blue. This, if we don't get them back immediately, within a certain amount of time, there is tissue damage, permanent tissue damage. And that's why you'll see like physicians all the time, they'll code for a period of time and be like, that's it. Yeah, maybe we'll bring them back, but they're going to be a vegetable, right? Coding patients is not nice. All right, it's not like in the movies and stuff, and they're like, oh yeah, no, you're breaking ribs, you're cracking sternums, you're electrocuting patients. It's not nice, okay? Especially when they're very elderly, stuff like that. Like it's not nice on the body. And then the risk of brain damage, stuff like that. After a certain amount of time, there's no oxygen circulating properly. There is damage. Okay. What time is it? 12:22? Look at that. And we finished lymphatics and we'll move on to immunity. We are cruising. So, let me just confirm something. Lymphatics, yeah, immunity. Okay. There's a little bit of lymphatics in here, but we kind of covered a good amount of it already. So lymph, that's the fluid. The lymphatic vessels, that's the pathway they travel. Lymphatic tissue, this is where we see clumps of these cells together. And then lymphatic organs, that's like your lymph node, spleen, thymus. So we'll see tons of cells here. They're kind of meeting at a central point before continuing on. So we talked about absorption of fat. That's the one big role of the lymphatics. Draining of interstitial fluid so we don't have edema, and then immune function. They're superficial. So as things penetrate our barrier, they can sample it and mobilize, the immune system. So we'll see a lot of lymphatics near entry points of the body, entry points potentially, entry points through the gut. So you'll see it's sampling in case something makes it into the system. We can get the immune system ready to go. That's why when you get sick, you'll notice your lymph nodes will swell rapidly. They can be sore, a little tender, and that's because all the cells in there clone themselves, expanded, and are ready to go. You made many, many, many of them in a very short amount of time, and that's why the tissue becomes tender. Blind-ended, they have valves in them, and basically what's in here, when you talk about lymph itself, it's the same thing as interstitial fluid. It can have proteins, it may not have proteins, it just depends on what migrates in there. So they're similar to veins, they have valves, muscle milking, and breathing also can move it just like veins. You won't find lymphatics in the CNS, epidermis, cartilage, just like you don't find vessels there freely, okay, especially in epidermis and cartilage. The lower body and intestines, they flow through cisterna chyli, and from that into thoracic duct, and from that into left subclavian vein into the bloodstream. So we'll see here, there's a split. So the upper right half of the body drains into lymphatic duct or by the lymphatic duct. The left side of the body and then entire lower portion of the body is drained by the thoracic duct. There's a little bit of a split there. So right lymphatic duct, right side of head, right arm, right subclavian vein. Entire left side of the body and lower body, left subclavian vein. All right. Diffuse lymphatic tissue. So this is where they're scattered. Where are we going to find them? Entry points. All of these are entry points to the body. Areas open to the exterior. When they're, depending on where they're at, you can see like mucosa-associated lymphatic tissue or MALT, GALT, BALT. There can be tumors in here. I actually saw one as a student. A lady had a maltoma in her stomach, and it was just mucosa-associated lymphatic tissue that had become a tumor. It was a pretty bad one. Nodular, so we looked at nodular in Peyer's patches in the ileum. So they're kind of encapsulated. They're clustered together. Once again, there's bacteria there. It needs to sample it. It stimulates the immune system, protects us if something makes it in. Tries to, at least. Tonsils, we learned tonsils are part of the immune system. We used to yank them out, pharyngeal, which are adenoids, palatine, and lingual. We used to take out the pharyngeal and the palatine. They still do. If they're having repeat, like strep throat, they can be colonized. I used to snore as a child, and so that's why I had my pharyngeal and palatine. The pharyngeal grow back, and so that's probably why my wife complains that I snore now. I don't believe her, though, because I never hear it. You know, it's really bad when you wake yourself up from your own snoring. That's a rough one. You know, you're just like, right? It's happened, unfortunately. Ah, all right. So lymphatic organs, bone marrow falls under there. We'll see, you know, this is where we generate our white blood cells. This is where we train the B cells. NK cells are innate cells. They're not specialized. And then T cells, which are immature, they will go on to the thymus to mature and be trained. You know, the thymus kind of shrinks as we age. It's not as big and functional as much as when we are younger. Spleen, this is where we really filter a lot of our blood. There's tons of white blood cells in there in the white pulp. The red pulp is like the pathways through. That's the sinuses. So as we push blood through and through the white pulp, the white blood cells will like kind of scan everything and pick off any bacteria, especially encapsulated bacteria, viruses, old cells, all of that, and deal with it as it goes through there. So spleen definitely plays a role in our immune system. And this is a real image here. And it's pretty neat because it shows like the reticular fibers, and then you can see the little white blood cells latched on there. And as blood flows through these gaps, they pick off those cells, filter our blood. So lymph nodes, as far as their structure goes, we have the afferent vessels that's coming in, efferent is leaving. So as fluid comes through and bacteria comes through, there's immature cells in there, these B cells. And what will happen is we'll stimulate them in the germinal center. They will go on to the medullary cords and they'll differentiate, they'll specialize for that specific bacteria. And then they'll clone themselves very rapidly. The clones are trained for that bacteria, and that's the proliferation stage. That's where your lymph nodes swell rapidly. That's lymphadenopathy. So when we see that, we know there's potential infection in the body and the immune system is responding. We should see it bilaterally. You see it on one side, you start to get concerned about cancer. If it doesn't hurt, it's been swollen for a while, that's not a good sign. Okay? Sometimes people do just have a big old lymph node. One of my sisters had one when she was younger. They removed it just to be sure. Not a big deal. Okay? So they're filtering everything before it makes it into the bloodstream. That's the goal. So if something gets in my skin, it gets into the lymphatics, it gets the lymph node, we filter it before dropping into bloodstream and spreading everywhere. All right, non-specific immunity, which is innate, versus specific, which is adaptive or acquired. Innate, it's what you're born with. It's okay. It works. But specific is what you train. Every time you get a vaccine, every time you get sick, every time you come into contact with an antigen, you create a lineage that deals with it. You create antibodies to deal with it. You create CD8 cells to deal with it. You clone all these cells to reserve them for later. The more you poke this bear, the better. It is infinite. For every time you come in contact with something, it creates a lineage of immunity against it. The more often you come into contact with it, the bigger that lineage is. More troops, more and more. So you come into contact, the quicker you can kill it off, the quicker you can deal with it, the faster the response, the less chance the organism can take hold. So that's in part why we give, vaccines where they're stepped. We give multiple vaccinations because we're getting that immunity high enough to where if you come into contact, you can deal with it. It can't take hold. Okay. So non-specified or innate immunity, that's just general. It's, like I said, not the greatest. Whereas specific immunity is specific to each individual antigen you come into contact with. Antigen is like a name tag on that structure. Everything has a name tag on that structure except for like O negative blood, technically. So innate, who falls under it? Skin. Does it work? Yeah. Can stuff get by it? Yeah. Okay. Mucous membranes, stuff gets stuck in it, we can deal with it. Acid in your stomach, the mucociliary escalator, those all play a role in it. The acidity of your urine. It's kind of most of it. Defensins in your skin. The salinity of your sweat. Those are all innate defenses. And then we have some cells that are also, that play a role in that. So like those NK cells, natural killer cells that we mentioned, phagocytes in general, like macrophages, monocytes. Okay. Inflammation plays a role in this. The antimicrobial proteins, that's like defensins, and then fever. Every time someone gets sick, what's the first thing they do? Well, here's some Tylenol. Here's some ibuprofen. Don't have a fever. It's so bad. No, it's not. Fever is a good thing. Fever upregulates your immune system, upregulates the use of nutrition that's floating around so organisms can't get to it. Fever is good. Now, that being said, low-grade fever is good. High-grade fever, not good. Over 103.9 is a high-grade fever. Damage can happen. So we do worry about that situation. Regular fever, not so bad. Adaptive, we're going to see two lineages, humoral and cellular. Under humoral are the B cells. This makes antibodies. The T cells, specifically the CD8 T cell or T cytotoxic T cell, that's the killer cell. He's the one that goes out and kills infected cells. That's what he targets. These two we train. Every time you get exposed, you train both simultaneously. So non-specific, first line of defense, not the greatest, okay? So these guys that we talked about, acidity of the stomach, vaginal secretions are acidic, lysozyme, and every bodily secretion, urine itself, those are all chemicals that can help inhibit growth. There's mechanical also, so like the mucociliary escalator that we mentioned. And then urine itself, like as urine is flowing out, it is pushing the bacteria out, moving it along. Non-specific, so cells that can undergo phagocytosis, really it's all of them. Here they really just say macrophages, neutrophils, and really they all can, but that's fine. NK cells, these are untrained lymphocytes. So we're going to look at the lymphocytes and we'll see there's CD8, CD4, B cells. Those are all lymphocytes. But the untrained lymphocyte is the NK cell, natural killer cell. He's typically related to killing off cancer in your body. Basophil mast cells, one and the same. They release histamine and then in heparin, and then eosinophils. These are commonly related to dealing with parasitic worms, but here in the US, it's really clean, so usually allergies. Okay, complement, we'll talk about floating around in your bloodstream and their function, and these are real images. That's a white blood cell phagocytizing something, some bacterial cell, white blood cell also. So that's the pseudopodia that they grow in order to phagocytize something, that false feet that it grows around it and engulfs it and pulls it in. So this is phagocytosis. This is going to play a crucial role for us when we talk about the adaptive side. But what we're doing is we're eating, we create a phagosome, we take a lysosome, fuse them, that's a phagolysosome, destroy it, eject it. That's exocytosis. When we talk about it with the training the adaptive immune system, we're going to present the antigen here and train the adaptive immune system. That's another real image too. Pretty wild looking. NK cells, so these work on typically virally infected cells, and they work in a pretty neat way. The CD8 cells also work in the same way. They release perforins, they punch a hole into the cell. Then they inject granozymes. Granozymes go into the cell and they tell the cell, open up all your lysosomes. The cell undergoes commanded cell suicide or apoptosis. It dies, macrophage comes in, cleans up the debris. Typically we say cancer or abnormal body cells, technically virus cells, but really for virus cells, we're going to say CD8. That's who we're going to say is concerned with that. Really NK cells, abnormal or cancerous cells. Inflammation, 4 signs of inflammation: pain, redness, swelling, heat. Well, what happens? White blood cells will migrate to there. They'll enter into the tissue. They'll walk over there. They'll attract more. Well, they release a couple things. They release histamine. Histamine, vasodilator. So what happens? More perfusion of tissue. That hydrostatic pressure pushes in. So what happens? We start to compress the tissue. Because we're dilating the vessels, there's the redness. Blood is more near to the surface. Swelling, because there's more perfusion of the tissue. There's more fluid in there, interstitial fluid. Because we're compressing the tissue. Pain, because we're compressing the nerves. And then heat, because blood is closer to the surface. So that's the 4 signs of inflammation: pain, redness, swelling, heat. Why? Histamine. Leukotrienes are just chemical communicators between white blood cells. Tractions, kinins play a role in inflammation. Okay? Mast cell, him and basophil is really one and the same. You release heparin, there's that increased blood flow. Phagocytes can be messaged to come help with cleanup. Heparin, capillary permeability. They can activate complement that we'll talk about. Activate clotting. Regional temperature increase because dilation of blood vessels, capillaries, and defensins can be activated to kill off organisms and whatnot. Fever. How do we raise temperature? We release chemicals from the white blood cells. They're pyrogens. The pyrogens go to the hypothalamus and tell it increase body temperature. Well, how does it increase body temperature? 1, vasoconstrict the periphery. Keep the blood in the core. Increase body metabolism. Whenever we elevate temperature, increase the activity of enzymes. You burn through stuff. Okay? So we undergo higher cellular respiration, consume nutrition, more activity of white blood cells, and less food source for invaders. Low-grade fever. Interferon interferes. So it's kind of easier to explain here. Here's a virus, and it infects a cell. The cell goes, uh-oh, we're in trouble, and generates interferon. Interferon goes out and goes to the neighboring cell. When the virus leaves the original cell and infects the neighboring cell, it interferes with his ability to use his ribosomes. Viruses don't have ribosomes, so they hijack our cells to use the ribosomes to make proteins. So interferon interrupts their ability to use neighboring cells. So we have synthetic interferon or interferon that we've generated, and we'll put it into patients to slow viral infection of cells or progression of virus in certain diseases. Problem with it is it degrades pretty quickly. You have to infuse it over several hours, several times a week. It's not a viable option for everyone. And I'm going to stop there. That's a good stopping point. Okay. Any questions? If not, I will see some of you today, and I'll see the rest on